Good day, dear learners. We are now on to Module 5M, the last concept for your midterm coverage. I hope you viewed the pre-recorded endocrine discussion part 1, where we discussed the endocrine system as well as the other video materials uploaded in our unit. Your learnings on these presentations and videos will help you out a lot in understanding its disorders or the imbalances. Now, as I start my discussion, I hope you give me your time and your attention. Before we tackle onto the specific disorders, let us briefly look into our objectives. For our objectives, we are going to discuss the hypo and hyperfunction of the different glands of the endocrine system, and I will also briefly discuss the conditions along with its management. For the anterior pituitary gland, the hyperfunction would include gigantism and acromegaly. For its hypofunction is dwarfism. For the posterior pituitary gland, the hyperfunction would include the syndrome of inappropriate antidiuretic hormone. We also have the hypofunction, which is diabetes insipidus. For the thyroid gland, for hyperfunction, we have the Graves' disease. For the hypofunction, we have the mixed edema. For the parathyroid gland, we have the hyperfunction of the hyperparathyroidism. For its hypofunction is for its hypoparathyroidism. For the adrenal gland, we have the hyperfunction, which includes Cushing syndrome and the pheochromocytoma, and for its hypofunction is the Addison's disease. Now, to start with our discussion onto the hyper and hypofunction state, we start with the pituitary gland. Now, we know that the pituitary gland produces hormones that affect multiple body systems. That is why it is referred to as your master gland. It also targets tissues that includes the thyroid, adrenal cortex, the ovary, the uterus, the mammary gland, the testes, and the kidneys. And its disorders can be due to a pathological condition from the gland itself or to a hypothalamic dysfunction. The anterior pituitary specifically secretes the following hormones. We have the growth hormone, or it is also referred to as your somatotropin, the prolactin hormones, the thyroid stimulating hormones, the adrenocorticotropic hormones, the follicle stimulating hormone, and your luteinizing hormone. Now, common disorders associated with the hyperfunction of the anterior pituitary gland involves the growth hormone or somatotropin. One example of which is your gigantism. With growth hormone, it is produced by the cells in the anterior pituitary throughout life. It is necessary for growth and also contributes to metabolic regulations. Your GH, or your growth hormone, stimulates all aspects of cartilage growth and the growth of your epiphyseal cartilage plates of the long bones. Now, what happens with gigantism, there is hypersecretion of your growth hormone. It begins before puberty and closure of the epiphyseal plate. That is why the person becomes abnormally tall and its body proportions are relatively normal. With the height, they can exceed over 6 feet and 11 inches or 213 centimeters. Now, on the picture that you see on your slide, this is Sultan Kosen. He is one of the tallest man in the world according to the Guinness Book of World Records. His height is at around 8 feet and 3 inches. Another hyperfunction of the anterior pituitary gland, specifically with growth hormone, is acromegaly. Acromegaly is a bit different with gigantism because this time, with this condition, your growth hormone hypersecretion begins during adulthood. So, with acromegaly, it literally means enlarged extremities. It is commonly caused by pituitary tumors, and its manifestations are forehead enlargement, the maxilla lengthens, there is tongue enlargement as well, and the voice deepens. Now, other manifestations would also include peripheral nerve damage, swelling of hands and feet. There is also joint pain. There's headache. There's gaps between the teeth, barrel chest, thick and oily skin, strong body odor, and also hypertension. For the surgical management for acromegaly, there is a surgical removal or irradiation of the pituitary tumor, wherein there is a surgical procedure called transsphenoidal or transfrontal. The goal of the surgery is to remove the tumor that causes the excess of growth hormone. However, there is a slight disadvantage because you may need to have 2 operations or more because there is still recurrence. So with their transsphenoidal approach, they insert the endoscope and the curette into your nose. For the management, of course, you need to take the history and physical examination because you can literally and you can really see the physical changes of a person with hyperfunction of the growth hormone, evaluation of plasma insulin-like growth factor 1 levels. So the peripheral actions of your GH are mediated by this insulin-like factor growth. And if your GH levels rise, so do your IGF-1 levels. Your serum IGF-1 levels, they are reliable diagnostic tests to measure your acromegaly. Another is your oral glucose tolerance tests and MRI, if just to assess and check if what causes the hyperfunction is the presence of a tumor. Now, there are nursing responsibilities that we need to consider after hypophysectomy, after the removal of the gland. So you have to elevate the head of the patient at all times at 30 degrees angle. This is to avoid rather pressures on the sella turica, and it decreases headaches as well. You have to perform mouth care to keep the surgical area clean, though you need to avoid toothbrushing for at least 10 days to protect the suture line. Advise the patient not to cough, sneeze, or brush the teeth, as what I've mentioned. No coughing and sneezing. This is to protect the suture line and as well as prevent CSF leakage. You also need to constantly check the nasal packing. Clear nasal discharge would mean that there is CSF leakage. So if and when there is a clear nasal discharge, you need to send it to the lab for glucose tests. So if glucose level is greater than 30 mg per dl, it means or it indicates there is CSF leakage. And if there is an CSF leakage, it means there is a higher risk for meningitis. So we also need to avoid or assess rather signs of meningitis, which include severe headache, nuchal rigidity, positive Kernig's sign, and positive Brodzinski's sign. Monitor for signs of increased intracranial pressure, such as high BP, low heart rate, and low RR. Another management for the hyperfunction is also radiation therapy. The radiation therapy is only used when surgery has failed to produce a cure or when the patient is a poor candidate for a surgery. This is usually offered in combination with drugs that reduces the growth hormone levels. However, the full effects may not be noted for months to years. The radiation can also be used to reduce the size of a tumor before surgery, and radiation therapy may lead to hypopituitarism, which then requires lifelong hormone replacement therapy. So drug therapy, which is also used for the hyperfunction of your or for your acromegaly, is your octreotide acetate or sandostatin. No? So this is a somatostatin analog that reduces GH levels to normal in many patients. This is given subcutaneously through injection 3 times per week, or in a week. We also have long-acting analogs like your octreotide, sandostatin LAR, and lanreotide SR or sumultin depot. These are available as intramuscular injections given every 4 weeks. GH levels, if you have drug therapy, GH levels are measured every 2 weeks to guide drug dosing, and then every 6 months until the desired response is obtained. Now, drug therapies are most commonly used in patients who have had an inadequate response to surgery and or is a combination for the radiation therapy. Now, for the hypopituitarism, which is a very rare disorder that involves a decrease in one or more of the pituitary hormones. If there is a deficiency of only one hormone, we refer that as a selective hypopituitarism. However, if there is total failure in the pituitary gland, which results in deficiency in all of the pituitary hormones, then we refer them as your panhypopituitarism. One example of your hypopituitarism or a condition is your dwarfism, where there is an insufficient secretion of growth hormone during childhood, which results in generalized limited growth. So most usually caused by a tumor. So for the management of the hypofunction, it's surgery, radiation therapy, and hormone therapy. For hormone therapy, we can have somatropin. This is a recombinant human growth hormone used for long-term hormone therapy in adults with GH deficiency. It can give you an increased lean body mass. It increases the person's energy, and it also improves body image. Now we proceed to the posterior pituitary. Posterior pituitary, the disorders of the posterior pituitary gland are related primarily to excessive or deficient antidiuretic hormone. Now we remember that there are only 2 hormones involved or secreted in your posterior pituitary, one of which is your ADH or your antidiuretic hormone. The other one is your oxytocin. Now, for the hypo and hyperfunction, this is commonly associated to the ADH. So for the hyperfunction, one example of which is your syndrome of inappropriate antidiuretic hormone. There's high levels of ADH in the absence of serum osmolality. Now, normally, your antidiuretic hormone is secreted in response to serum osmolality. Now, if there is a hyperosmolarity state, ADH secretion increases and renal water is reabsorbed. And if we have the opposite, if there's hypoosmolality, it causes the suppression of ADH and renal water excretion increases. Now, with syndrome of inappropriate antidiuretic hormone, common cause of which is malignant tumors, it results in water intoxication or retention. There is hyponatremia and there is hypoosmolality. For the manifestations of the SIAD-H, I hope you can, the picture on your screen can help you out. Remember, with SIAD-H, meaning you are soaked inside meaning there's too much water inside your body. So the manifestations would include brain cells will swell, signs of fluid overload because there's too much water inside your body. There could also be changes in the level of consciousness and mental status changes, and this could be due to the swelling in the brain cells, which causes neurological symptoms, which includes headache, changes in mental status, as what I've mentioned, lethargy, and irritability. Now, there's also weight gain without edema. Weight gain without edema, this is because of the retention of the fluid. Usually, edema is not present because or is not manifested because water is distributed between the intracellular and extracellular spaces. We also have hypertension, tachycardia, tachypnea, and rales, anorexia, nausea, and vomiting. And of course, we have delusional hyponatremia. Now, usually, these manifestations of SIAD-H occur because of excess in water. This is in relation of the excess of water in the body. Okay, so the management for SIAD-H, of course, would be geared towards restoring normal fluid volume. So if we would like to have that or attain that one, there's a need for us to do water restriction. This is to prevent further hemodilution, increased water in plasma. So water restriction less than 800 ml per day. Give hypertonic IV solutions, give ice chips because there's water restriction. Increase sodium because you have hyponatremia. And of course, increase potassium in the diet as well. Monitor for patient safety since there were also neurologic changes or mental level of consciousness also had an effect on that. And of course, you have to also promote diuresis. So you can do this by administering furosemide Lasix, your demeclocycline. Your demeclocycline is a tetracycline antibiotic with a unique property of creating excessive urine flow. So the treatment really is geared towards addressing the low serum sodium and the swelling as well as the excess of water. Now, the opposite of your SIAD-H is the hypofunction or deficiency of your ADH is your diabetes insipidus. In the drawing, I hope also you can easily remember what is diabetes insipidus because you are dry inside, or DI, which is dry inside. This results to the inability of the body to conserve water, thus excreting large amounts of fluids. We have two types of diabetes insipidus. We have the neurogenic, which results from the disruption in your hypothalamus and pituitary gland, which could be caused by a trauma, radiation, or a surgery. And we also have nephrogenic, which is the renal tubules are not sensitive to the antidiuretic hormone and does not absorb water, which could be a result of a renal failure. So some of the manifestations of your DI or your diabetes insipidus, you have polyuria, as mentioned a while ago, wherein you'll be excreting large amounts of urine. In some instances, you can excrete as much as 12 liters per day. You also can experience polydipsia, meaning the person has extreme thirst and tends to drinks large amounts of water. And if you are unable to replace water loss, then there's a tendency for you to become dehydrated and hypernatremic. There's too much salt inside your body. And there's also decreased skin turgor, dry mucous membrane, low urine specific gravity as well. Now, if the deficiency was caused by a cerebral injury, symptoms commonly appear 3 to 6 days after the injury, and it lasts 7 to 10 days. If the increased intracranial pressure is relieved, then the DI symptoms also usually disappears. For the diagnostic test, we have the water deprivation test. The patient is deprived of water for 8 to 12 hours. And then after that, they are given or they will be taking medication, desmopressin acetate. This is given subcutaneously or nasally. And if the patient has DI, they exhibit a dramatic increase in urine osmolality and a significant decrease in urine volume. However, if the patient has nephrogenic, meaning the kidneys has a problem, they will not be able to increase urine osmolality to greater than 300 MOSM per kilogram. Management for our DI is, of course, you need to monitor vital signs and neurological and cardiovascular status. You have to also monitor for the fluid and electrolyte balance. Monitor I and O, the weight of the patient. You have to remember that by weighing of the patient, 1 kilogram in excess would also mean 1 kilogram addition to the weight of the patient. And then maintain, of course, adequate liquids. Instruct client to avoid foods and liquids with diuretic action because we don't want to increase further the large amount of urine being excreted. And of course, administer desmopressin acetate. That is the drug of choice for the diabetes insipidus. Desmopressin acetate causes increased water reabsorption. Now, to proceed on to the next gland, we have the thyroid gland. The thyroid gland, alterations of this gland is the most common in the endocrine disorder. Your T3 and your T4 regulates metabolism and growth and development. And we also need to remember that the thyroid uses iodine to secrete the thyroid hormone because some of this hypersecretion and hypofunction also involves the deficiency or excess of your iodine. And your thyroid hormone is also very important or is vital in the development and maintenance of brain function and other organ systems. And one example of the hyperfunction of the thyroid gland is your Graves' disease. This is the most common cause of hyperthyroidism, and it also referred to as your toxic diffuse goiter. Hypothyroidism, by the way, is also referred to as thyrotoxicosis, meaning it's a disorder caused by excessive functional activity of the thyroid gland. Now, it is also important for us to remember the primary function of the thyroid gland so that by the time we are going to discuss the manifestations, we can relate it and associate it immediately. Now, the primary effect of the thyroid hormone is to increase metabolism, protein synthesis. Thus, if you have hyperthyroidism, we will be having problems such as increased basal metabolism, weight loss, lipids are depleted, and glucose tolerance will also decrease. With Graves' disease specifically, it's caused by an autoimmune disorder mediated by immunoglobulin G or IgG antibody that binds to and activates your TSH receptors on the surface of the thyroid. Here are the manifestations of your hyperthyroidism or your Graves' disease. People with Graves' disease have enlarged diffuse thyroid gland or your goiter, but with the goiter, it may also be present as a consequence of both iodine deficiency or excess. So meaning to say that goiter can be manifested with patients having hypothyroidism. Another manifestation is your proptosis. Proptosis is the forward displacement of the eyes, and as well as exophthalmos, which is forward protrusion. Now, common ophthalmology of Graves' disease is the proptosis, and there are also visual dysfunctions. So exophthalmos can also result from an accumulation of inflammation of the byproducts of in the retroorbital tissue. Now, because there's compression and stretching of the optic nerve, the person may exhibit or experience blurring of vision, diplopia, eye pain, lacrimation, and photophobia. If and when the eyes could not fully close, there's also the tendency for the patient to manifest eye dryness. Other manifestations would also include severely or extremely agitated and irritable individual. There are hand tremors at rest, a big appetite with weight loss, speed up bodily processes. That's why they can also manifest increased bowel motility, or there's loose bowel movement. There's heat intolerance, there's palpitations, there's profuse diaphoresis, there's tachycardia, there's incoordination, and cyclic moods. Basically, these manifestations are associated with hypermetabolism. One of the complications of hyperthyroidism is thyroid crisis, or this is also referred as your thyroid storm. It is an extreme state of hyperthyroidism, and this could be due to untreated hyperthyroidism. This is a potentially fatal acute episode of thyroid overactivity, which is characterized by high fever, severe tachycardia, delirium, dehydration, and extreme irritability. So your thyroid storm, mortality is very high, so rapid treatment is necessary to preserve the life of the patient. The management, of course, for hyperthyroidism is it all includes nutritional status. So you give high caloric, high protein, and well-balanced diet. You have to remember that with hyperthyroidism, metabolism is increasing, or there's over metabolism, no? So of course you need to also decrease stressful situations, because stress increases circulating catecholamines, which further increases or aggravates a problem. Improve self-esteem, because there's also physical changes. Maintain normal body temperature, because the patient is heat intolerant. And of course, manage potential complications. For the medications, we have antithyroid medications. These are recommended for clients younger than 18 years of age. And for pregnant women, we have the propylthiouracil and the methimazole papazole. Adjunctive therapy could include iodine therapy. This is to reduce the vascularity of the thyroid gland if before it can be used as preparation before a thyroidectomy and to treat thyroid storm. A choice for the iodine therapy is your SSKI, or your saturated solution of potassium iodide. Iodine preparations are usually given only 10 to 14 days before the surgery. Another adjunctive therapy could be the use of your propranolol. This can control nervousness, tachycardia, tremors, anxiety, and of course heat intolerance. Another management we can do for hyperthyroidism is radioactive iodine therapy. Now, because the thyroid gland takes up iodine in any form, radioactive iodine 131 concentrates in the thyroid gland damages and destroys the thyroid cells. So this is prescribed mainly for middle-aged and older clients. So after receiving this therapy, the clients may go home unless the dosage is extremely large, and they would require isolation for several days. For radioactive iodine therapy, the results can occur in 6 to 8 weeks, and if the woman of childbearing age should undergo radioactive iodine therapy, they should delay becoming pregnant for 6 months, and for men, they should allow 4 months for sperm turnover production. Surgery would be thyroidectomy, removal of the thyroid gland. This is recommended when other treatments are not effective, and or if the nodule is too large and there is obstructive symptoms. By obstructive symptoms, it would mean there is already pressure in the esophagus or trachea that causes breathing or swallowing problems. For thyroidectomy, we can opt to have subtotal thyroidectomy or total thyroidectomy. For subtotal thyroidectomy, it leaves enough portions of the gland to produce adequate amounts of your thyroid hormone. For the total thyroidectomy, it's the complete removal of the gland, and it requires lifelong hormone replacement. What are your pre-operative preparations? Of course, we need to make sure that the client is in euthyroid, meaning normal as possible. Before the operations, the state of the thyroid gland is as normal as possible. Administrations of antithyroid medications and iodine preparations could also be done prior to the surgery to be on that euthyroid state. This is to also help out decrease the vascularity and size of the gland, which reduces the risk of hemorrhage during and after the surgery. So clients should also be adequately rested, at optimal weight, and in good health. Usually preparations may take as long as 2 to 3 months. With post-operative care, you have to maintain patent airway and observe for respiratory distress. Respiratory distress may result from hemorrhage or edema, which may compress the trachea. You check for hemorrhage, you assess the dressing, and of course check the neck area. The position of the client post-operatively is in semi-Fowler's position. You have to decrease, this is to decrease neck strain on the suture line. Of course, you also need to assess laryngeal nerve damage, as this is one of the potential complications. Although initially after operation, there's hoarseness of voice, which is expected. This is because of the edema. But if and when permanent hoarseness is observed, then laryngeal nerve damage is a complication. And then, of course, another is we need to assess for tetany. Tetany is a possibility because the surgery can also decrease. There's a possibility that the circulating calcium levels has also decreased. So how do we check for tetany? You are to check through these signs, your Chebostic signs and your Trousseau sign. Later on, I'll be letting you see a picture of what is Chevostic and Trousseau when we go to hypoparathyroidism. For the hypothyroidism, we have the mixed edema, causes of which would be an undiagnosed or untreated hypothyroidism that includes stress. Hypothyroidism is a disorder that results when the thyroid gland produces an insufficient amount of your thyroid hormone. Uh, it causes generally slowing of the metabolic rate, which is opposite of the hyperthyroidism. So with this hypothyroidism, uh, generally its manifestation would be associated with the slowing of the metabolic rate. The hypothyroid state in adults is called mixed edema, while in children we call that cretinism. So let's just focus with mixed edema. Mixed edema alters the physical appearance of the skin and subcutaneous tissue with puffiness, facial and preorbital edema, and mask-like face. So the mixed edema is also characterized by a dry, waxy type of swelling with abnormal deposits of mucin in the skin and other tissues. You can have edema, which is a non-pitting type, and it's common, as what I've mentioned, in the pretibial and facial areas. Severe state of your mixed edema is your mixed edema, which is a life-threatening complications if you have an untreated hypothyroidism. It can be precipitated by infections, or if you are exposed to colds or to certain medications like opioids, tranquilizers, or barbiturates, or trauma. Here are the manifestations of your mixed edema. We have hypercholesterolemia, hyperlipidemia, extreme fatigue, hair loss, brittle nails, dry skin, numbness and tingling of the fingers, husky and hoarseness of voice. There's menstrual disturbances, decreased libido, weight gain, even if without increase in food intake, expressionless or mask-like face, and is cold intolerance. This is opposite with hyper, which has the heat intolerance. For the medication, we have the thyroxine or T4 levothyroxine. This is the preferred therapy. You have to monitor for the heart rate and report pulse greater than 100 beats per minute or an irregular heartbeat. In a patient without side effect, the dose is increased at 4 to 6 weeks interval, or it may take up to 8 weeks before the full effect of the hormone therapy is seen. With this, it is important for us nurses to let the client understand to still take the medication regularly. Management would also include modifying activity, assist with care and hygiene, encourage participation in activities as tolerated, monitor for physical status like vital signs and cognitive level, promote physical comfort, you provide extra clothing, blanket, but of course you need to avoid heating pads and electric blankets because they are prone to burns because they are cold intolerant, and enhance coping measures. Now, onto your parathyroid gland. The disorders of the parathyroid gland are not as common as those with your thyroid gland. Your parathyroid hormones, of course, helps regulate serum calcium and phosphate levels by stimulating bone resorption of calcium, renal tubular reabsorption of calcium, and, of course, activation of your vitamin D. The hyperparathyroidism results from increase in the secretion of your PTH or parathyroid hormone. And again, it is responsible for regulating your serum calcium levels and phosphate levels. So if you have hyperparathyroidism, it is characterized by bone decalcification and the development of renal calculi or kidney stones containing calcium. For its manifestations, you can have skeletal manifestations, which includes bone and joint pain, backache, pathological fractures because your bones are giving off too much calcium, ribs, long bones, deformity and bending of the bones. In the renal system as well, so in your kidneys, you'll have polyuria, polydipsia, appearance of a sand gravel stone in the urine. You have azotemia, hypertension due to renal damage. For its management, you have to lower the severely elevated calcium levels. We need to have hydration, low calcium, low vitamin D in the diet, and Lasix, that is to also excrete excess calcium levels through your kidneys or through urine. Fluid intake should be increased to 2,000 ml or more. That's also to prevent kidney stones formation. Mobility is encouraged so that bones would give up less calcium. And we also have a surgery, which is parathyroid. A complication identified with parathyroidism is your hypercalcemic crisis, wherein the serum calcium levels is more than 15 mg per dl. This results in neurologic, cardiovascular, and renal symptoms. This can be life-threatening. Emergency, you give calcitonin and corticosteroids. For calcitonin, this is basically, it helps regulate calcium levels in the body by inhibiting bone resorption and increasing calcium excretion in the kidneys. Corticosteroids, on the other hand, it reduces serum calcium concentration by reducing intestinal calcium absorption. Now, the opposite of your hyperparathyroidism is your hypoparathyroidism, wherein your serum calcium levels are abnormally low. Serum phosphate levels are abnormally high because they have an inverse relationship, and there's also pronounced neuromuscular irritability or tetany will also develop. Now, due to the reduced PTH, the ability to reabsorb calcium from bones and to regulate calcium reabsorption from renal tubules is also impaired. And with that, there's reabsorption of phosphate, which is increased. That is why we have hyperphosphatemia. With the low calcium levels, this causes the changes in the neuromuscular activity, which will be shown in manifestations. For the manifestations, we have spasms, painful muscle spasms, irritability, grimacing, tingling of fingers, laryngospasms, dysrhythmias as well. Positive Chavostick and Trousseau, how will you check it? You tap onto the masseter muscles in the cheek, and the client will twitch its muscles in the cheek. For the Trousseau sign, you need to inflate the BP cuff for at least 3 minutes, and there is a flexion of the extremity or the hand of the patient, as seen in the picture in front of you. And of course, there's hyperactive deep tendon reflexes, and the patient could also manifest circumoral paresthesia, which is the numbness and tingling sensation around the mouth. Drug therapy would include IV calcium gluconate, oral calcium replacements. Now, our goal is to increase calcium levels. We need to administer these calcium or drug therapies that involves calcium. Vitamin D is also very important because it enhances the absorption of your calcium in your GI tract. And of course, your diet would be low phosphate but high in calcium. To proceed with your adrenal gland has the medulla and the cortex. It secretes catecholamines like the epinephrine and the norepinephrine, the fight and flight response. And your catecholamines would also regulate metabolic pathways. which is responsible for catabolism so that we could meet our caloric needs. And it also helps in the basal metabolic rate. It also helps in the blood glucose level. So one of the conditions or diseases for the hyperfunction is your Cushing syndrome. This results from the overactivity of the adrenal gland, specifically in the cortex, with subsequent hypersecretion of glucocorticoids. So it occurs mainly in women 20 to 40 years old. And common causes would include the use of corticosteroid medications, or there's excessive corticosteroid production because of a tumor. So the manifestations for Cushing's disease can be seen in most body systems, and it could be related to excess level of the corticosteroids, though they can also exhibit symptoms of excess mineralocorticoid and androgen excess. So here are the manifestations. So corticosteroid excess causes pronounced changes in the physical appearance. Excess cortisol results in a redistribution of body fat deposits in the abdominal region. That is why we have central obesity. There's fat pads under the clavicle. There is a buffalo hump. You have moon face. We also have change in skin protein metabolism, which causes peripheral muscle weakness and wasting. Glucocorticoid excess also inhibits fibroblasts, resulting in loss of collagen and connective tissue. Thus, we have thinning of the skin. We have abnormal stretch marks there, easy bruising, poor wound healing. No? So these are the manifestations of a client with Cushing's syndrome. For the diagnostic tests, we have increased plasma cortisol levels, increased serum sodium and blood glucose levels, decreased serum potassium, and we also can do 24-hour urine collection for free cortisols. For medication, this is an adjunct therapy to the radiation or the surgery. It's given to control the symptoms. They do not affect a cure. Some of the sample medications is your mitotane and metrapone. These are adrenal enzyme inhibitor. They suppress the activity of your adrenal cortex, and they decrease the peripheral metabolism of your corticosteroid. For the surgery, if there's a tumor, it would be adrenalectomy would be indicated. You have to remove your adrenal cortex, or hypophysectomy if it is indicated if the disease is caused by a pituitary disorder. So there's removal of the pituitary. For the management, you have to decrease the risk for injury, assist in ambulation, protective environment or safe environment, frequently assess for signs of infection, encourage rest and activity, promote skin integrity. You have to avoid adhesive tapes improve body image, and of course verbalizations of feelings and concerns. On the opposite is your Addison's disease. This is the destruction or a dysfunction of the adrenal cortex. There's a chronic deficiency of the cortisol, aldosterone, and adrenal androgens, and this is accompanied by skin pigmentations. So with Addison's disease, the absent steroids low, meaning the patient is weak, small, and tan because there is skin pigmentations. To add on to the manifestations, really the primary manifestations are the result of elevated ACTH levels and decreased aldosterone and cortisol. Aldosterone deficiency affects ability of the distal tubules to conserve sodium. That is why sodium is lost and potassium is retained. So, meaning to say, extracellular fluid is depleted and blood volume is decreased. Thus, we have hyponatremia because sodium is lost, but potassium is retained, thus your hyperkalemia. Hyponatremia can cause dizziness, confusion, irritability, neuromuscular irritability. Hyperkalemia can also cause cardiac arrhythmias. Cortisol insufficiency also causes decreased hepatic glucogenesis. That's why we have hypoglycemia. And increased ACTH levels also stimulates hyperpigmentation. So with this, we have dark pigmentation of the mucous membranes of the skin. Addisonian crisis is a complication. This is a life-threatening response to acute adrenal insufficiency. This is triggered with surgery, acute systemic illness, trauma, or abrupt withdrawal of a long-term corticosteroid therapy. Thus, if you are administering a corticosteroid therapy, you do not abruptly stop the medication, taking the medications. If there's slight overexertion, exposure to cold, acute infection, or a decrease in salt intake, this can lead to circulatory collapse, shock, and death. If untreated, that leads to Addisonian crisis. The manifestation for Addisonian crisis is cyanosis and your classic signs of circulatory shock, which includes a high fever, weakness, severe penetrating pain in the abdomen, lower back, and legs, severe vomiting, there's diarrhea, hypotension, and circulatory collapse, shock, seizures, and coma. For the drug therapy for Addison's, we have Solucortef or hydrocortisone. This is to replace cortisol. Another medication is your fludrocortisone. This is to replace mineralocorticoids. We also have your prednisone. We can have your 5% dextrose in normal saline. Vasopressor amines for persistent hypotension. And of course, you need a lifelong replacement for corticosteroids and mineralocorticoids if there is adrenal glands, if the adrenal glands are damaged. For the management, we have to monitor the vital signs of the patient. You need to assess for weight changes, muscle weakness, and fatigue. Avoid physical and psychological stressors. Assess patient's skin turgor, mucous membrane. Encourage food and fluids for electrolyte balance. You have to make sure that there is a quiet, non-stressful environment. Perform all activities for patients during an acute crisis. Now, the last condition is, this is a rare condition commonly caused by a tumor in your adrenal medulla. So your pheochromocytoma is a condition involving the adrenal medulla where it results to an excess production of your catecholamines, epinephrine, and norepinephrine. This is one of the forms of hypertension that is cured by surgery. Most dangerous effect is there's peripheral vasoconstriction and increased cardiac rate and contractility with resultant to paroxysmal hypertension, meaning it is unpredictable. Now, your pheochromocytoma tends to have a sudden release of hormones which cause a sudden attack or onset of symptoms which may last for a few seconds or to several hours. Attacks are often precipitated by physical, emotional, or environmental stimuli. Okay, so meaning this is unpredictable. Manifestation is hypertension. It may reach up to 250 to 150, over 150. MMHG, we have triads of symptoms: headache, diaphoresis, and palpitations. And also 5H, hypertension, headache, hyperhidrosis, hypermetabolism, and hyperglycemia. For its diagnostic test, we need to also check onto the catecholamine levels in the blood and or in the urine. So if there is pheochromocytoma, so its levels are the catecholamines are increased if we check with blood and urine. We also need to get the 24-hour urine test because catecholamine secretions is episodic. That is why we need to do 24-hour collection. This is a better surveillance method. For surgery, we have adrenalectomy. For drug therapy, we have phentolamine, sodium nitroprusside, your phenoxybenzamine, and your propanolol. Thank you very much for listening. I do hope that you have understood this concept on our endocrine disorders.